Mexico, and we have Dr. Steve Henao that will be leading the case. Dr. Henao, can you hear us?
Good morning. I can hear you all. Great.
All right, welcome. Can you tell us a little bit about the case?
Sure thing. Let me have our slides up here for a second. These are my disclosures. Next slide. So we have a very pleasant 60-year-old little lady that came in with a history of critical and threatening ischemia of the right leg. Breast pain. She had gangrene of the great hallux that she's battled since 2020. She's had multiple interventions. You'll see that there's a mimetic stent shortly in the leg. And in early January of 2021, she had an exploratory surgery by one of my colleague vascular surgeons across the street, who I was lucky enough to get an operative note, which to all you fellows out there, it's extremely important to get as much information on these complex redos because you could be walking into an ambush. And so in this particular case, this lady had a Dacron common femoral interposition for an injury that had occurred in an outpatient lab. And so when my colleague went in and re-explored it, that was all thrombosed. So he excised that and created a right external iliac to profunda bypass with a 7mm PTFE graft. And then he did an endoscopic vein harvested great saphenous vein bypass from this 7mm PTFE graft to the below the knee popliteal artery. One of the key parts of the operative note that I was able to find, I quoted down here, the superficial femoral artery was occluded and the bypass graft was cut from this, and the stump of the superficial femoral artery was oversewn. So just from that, you can kind of start to see the complexity of some of these redo cases, and I think you're going to be seeing more and more of this, especially with the best CLI results and what that may imply, and I think hopefully you'll be having some fruitful discussions about that coming for the rest of the day. Next slide. I wanted to also share with you the ultrasound findings, and sometimes depending on where you get these results, it may not be very instructive, but here at least I can tell that the flow is monophasic essentially throughout the leg. The native vasculature is gone, but if this is all I had to go by, I might have different options in my mind. Next slide. So essentially what I'm looking at is a bypass graft. Again, with best CLI, we're probably going to see more bypasses, and so regardless of your specialty, you have to understand what graft surveillance means. I think you have to perform angiography on all severe bypass graft stenoses. So here's some numbers from the literature. Over 300 centimeters per second peak systolic velocities and bypass graft velocities under 45 centimeters, as well as PSV ratios over 3.5. Those are bad players. And this ultrasound that I had on this patient basically was much worse than that. Next slide. So the gold standard for great saphenous vein failure is still to have open surgical revision, and that's basically the game to beat. Essentially looking at primary patency rates from the literature that I've got on the right side here, that ranges wildly from 42% to 85% at 5 years. Next slide. So what are the factors that affect the long-term outcome? Here was a retrospective review of about 1,200 bypasses, all kinds of different interventions, including vein patches, jump grafts, interposition grafts, transpositions from the occluded vessel to a new outflow target, and balloon angioplasty. So this is an interesting paper because it basically has all kinds of modalities. And the zinger here is there was no difference in patency rate from the different revision procedures, the type of vein graft, the indications for the original procedure, or for patients with diabetes or renal disease. Next slide. The factors that affect the long-term outcome, looking at patient gender, age, indication for surgery, and vein graft conduit were not predictive of outcome. So basically the things that mattered were whether or not you had a bypass graft that went into the tibial or pedal level. They had significantly lower 5-year primary patency rates after graft revision. and grafts that required revision because of early lesion failure. In other words, a graft that was placed less than 6 months, typically if it goes down or starts to fail early, means that you're going to have problems keeping that thing open. Next slide. So I've seen on social media platforms and other things, people posting cases of great saphenous vein saves, and people exclaiming almost dogmatically that it's a great place for a DCB, but what's the definition of a great save? Well, we heard earlier that we should be looking at evidence-based things. So what I could find here was a meta-analysis of 179 patients. And of all that, there's only one randomized controlled trial and 2 cohort studies. And basically, there is absolutely no significant difference in any of the patency rates when you use a drug-coated balloon. So that may change your mind on how we're going to treat this next patient. Next slide. Drug-eluting stent. This is a great paper out of Hopkins, a retrospective study, 7 years. And basically, they used the everolimus Xience product, and the primary patency rate was quite good, 81%. Next slide. So basically, aggressive imaging surveillance is a must. Early graft occlusion requires that you correct the underlying cause. Graft stenoses are typically solitary and focal in over 80%, so it tends to favor reason that endo should work. Optimal therapy depends on the lesion length, the timing of occurrence, and patient comorbidities. Again, drug-coated balloon therapy appears to show no benefit, so you have to be careful about that, especially if you're looking at cost-benefit analyses that we haven't seen yet, but it would probably be a loser. But as usual, we want to see additional studies comparing the long-term efficacy of this. So with that, we'll go ahead and kind of hop into our images that I took this morning on this little lady. Again, I've got a great saphenous vein bypass that's coming off of a 7mm PTFE graft from the external iliac to the below-the-knee pop. So one of the things I've done here is perform radial access because I just didn't want to get into that big scar bed. The patient has a larger BMI, and the groin is quite hostile in terms of being able to get accurately in there. I also have the saphenous vein takeoff that you can see here. I toyed with the idea of going Antegrade, but I opted to at least hear your considerations on what you might do. So you can see the graft coming off here as it plugs directly into the profunda. You can see the mimetic stent in the thigh, and then you can see the graft coursing down. You can see the reflux of flow, which is a nice sign. So we don't have a complete failure of the graft at this point. And then as we get to the target here at the P3 segment, you can see that there's a big problem there. Tibial-wise, anterior and posterior tibial arteries appear to be robust. The perineal artery appears to have some diffuse disease, but since this is predominantly a great hallux lesion, that's going to be my angiosomal target, is kind of reperfuse the tibials in such a way that we're focusing on really the anterior tibial.
So, Dr. Henao, a very, very interesting case. Do you have a run of the foot as well?
Of course.
All right, perfect. So, my question, I guess, to the panel is, looking at this case, kind of starting for your approach, would you guys, in terms of access site, in terms of what kind of treatment you're thinking about based on the evidence that was presented and on your algorithm, maybe we can just go down the panel and kind of see what everyone would do here.
Yeah, this is an interesting case in terms of approach. So if the contralateral common femoral artery is not available or optimal for access, that would be the first thing I would look at. I would probably go pedal access in this case rather than a radial. The problem with radial is that you don't have all the equipment available just in case you need to rescue yourself to reach from the radial all the way down into the knee. So one has to be prepared to, and I can see that the foot is prepared just in case they need to go retrograde.
think that's a great point. Dr. Malik?
Yeah, I'm gonna echo those. I thought the bypass was, I can't remember whether the bypass was on the common femoral or the iliac to profunda bypass. I thought you said was on the right, but I didn't see it over here. But if the groins aren't available, then yeah, pedal access. I mean, we really do. I mean, angioplasty of the saphenous vein. I mean, saphenous vein can really tolerate quite a lot. They do well. I mean, doing an open revision of something like that would really not be feasible. I think you should get a very good result. I mean, a pedal access and just straightforward balloon angioplasty should do pretty well.
Yeah, I think that those are all great points. So, Dr. Hanau, just to confirm, that bypass, the saphenous vein bypass, is coming off the external iliac to profunda graft bypass. Is that correct?
Yeah, it's a 7 millimeter PTFE graft that they used to totally reconstruct everything since the common femoral artery was essentially sacrificed years ago.
It's interesting because there are branches coming from all that vessel. So I'm not sure if
I don't know where it is exactly. This is coming. This is coming off of his operative note.
It doesn't look like a. I don't see a bypass there really. Or maybe it might be something really short.
Yeah, unless they did a end to end, and those are maybe just early high profunda branches. But yeah, no, I think like Dr. Hanau mentioned, just knowing the history and knowing the op report definitely would are critical in this case. So you're getting PT, posterior tibial artery access?
Yes. So as you all have mentioned, the radial access options for us are limiting because of, I think, distance and whatnot. I simply did that just so that I could avoid having to go through that scar belly in the groin. And I picked the posterior tibial because it appeared to be the straighter shot.
Sorry, maybe I missed this, but was the left side also reoperative field? Is it possible to do contralateral access in this case?
Yeah, we did, but the amount of pushability that I was able to get on that side because of her bifurcation and whatnot was suboptimal.
Got it.
And just to confirm, this is your angiosome target. But this is your angiosome to her gangrene, right? The PT.
No, it's the AT.
Oh, it's AT. Okay.
Yeah.
Yeah, just to confirm, where's the location of the wound?
The great hallux.
Can I ask my surgical colleagues why we sacrificed her common femoral and tied off her SFA?
So
that doesn't make sense.
And then,
yeah.
More importantly, that supera stent looks lovely downstream. So, I mean, by sacrificing the common and the SFA, you've sacrificed any. I mean, as a cardiologist, when the vein grafts go down, we go to the native.
Right.
I'm perplexed by that. Can somebody please instruct me?
Yeah, so I think that is a little bit concerning because it sounded like the initial surgery was for some sort of complication during an angiogram. Is that what your understanding was, Dr. Hanau?
Yes, that's what I was hearing. There was an OBL mishap that led to acute limb ischemia event.
Yeah, so my impression...
And so they had to...
Yeah, my impression based on that is there was some significant common femoral artery injury that was, at least according to the vascular surgeon that did it, maybe unreconstructable, which is why they jumped from the iliac all the way down to the profunda. But that is a little bit strange that they couldn't do an endarterectomy or something to try to salvage the native vessel, because that adds a layer of complexity to that case as a result.
And also doing endoscopic vein harvest for bypasses is probably not what we would do in vascular surgery. I think that those don't do well because there's usually some sort of burn injury in that long length. That's great in cardiac because I think you're using short segments, but in vascular, when you're using such a long segment vein, I don't know, Jeet, are you using endoscopic vein harvest? I'm not.
No, I think that's a great point. I think most vascular surgeons will just harvest the vein surgically open. I think that's
the data shows it does worse usually.
Correct, yeah, for vascular surgery, even though they do it in cardiac surgery for bypasses of the leg, I think we'll do it open. But now, unfortunately, they've also kind of used that saphenous vein, on this patient who may have needed a tibial bypass or something down the road. So that's another downside to not reconstructing the autogenous arteries here. So, Dr. Hanau, can you just walk us through a little bit of kind of what wires you're using, if you're using any sort of medication when you do pedal access to prevent thrombosis, and what your plan is here?
Yeah, so we typically do, like it had been mentioned on the prior session, radial cocktail type, nitroglycerin or verapamil. I typically will go with an 018 platform, and I'll use a catheter instead of a sheath, but because this is going to be my primary site for treatment of this saphenous vein, we're using a 6 French slender.
And then maybe I'll open that up to the panel too for their pedal access. I mean, this is basically a primary pedal intervention. Would the panel do anything differently, or would they do this a similar approach here?
Ruby.
Similar, probably.
Yeah. And then in terms of crossing the lesion, maybe we can talk about what kind of wire catheter combinations you'd use from a pedal approach. Would everyone stick to 014 or 018 system or 035? And what are you thinking in terms of intervention to treat this this lesion in the bypass?
We'd like to see a better image of that distal anastomosis that hopefully we'll get soon. Generally in this location, I am always on 014. We just have more options available with 14 wires than you do on 18. But there are obviously differences. In this case, it's not a CTO that you have to cross, that you would that the choice of wire becomes important. Here's what becomes important is the availability of the various therapies on 014 versus 018.
Take a full strength.
I mean, if I have a difficult lesion to cross up from below, then I'll usually use an 18, but most of the therapies I'll do on the 14 itself.
The technologies with jacketed wires today, 014 almost invariably, they work really well. The coronary systems and systems out of Japan are so well steerable, so well penetrating that they will, with good technique, cross almost
Let's
anything.
do a
Yeah, no, I think
10 for 10.
I agree with all those comments. I think here I would definitely do a 014 system. Probably my choice is just to use a command or a whisper wire, something atraumatic to start, since we're not dealing with an occlusion, and then a quick cross. And I think that image shows it a lot better. So correct me if I'm wrong, but are you looking at a very tight lesion right at the distal anastomosis of the bypass? Dr. Hanau?
That's what it looks like. Yes, sir. Let me get a 018 Mongo.
And then what about for imaging? So, I mean, if you're doing primary pedal, one of the limitations is, you're obviously shooting against the direction of flow. So if others do this, will they put in just a micropuncture or something to shoot from above? Or how do you kind of optimize your imaging in these cases? Maybe I'll open that up to the panel again.
I like imaging from above. I think it's easier. You don't have to
Wire shaper.
Pull things and to get imaging, i.e. your wire. So I like doing that. I guess I'd ask, is this lesion focal? Because it looks like it's the whole distal part of this graft is actually down. So is there from a surgical standpoint, once you start working on this now, and I apologize, I don't remember how long or how old this graft is, but once you work on it and you start working on it from the native into this graft and into this distal segment, what's the time frame for failure? And when do you consider a success a success? Is it 6 months? Or is it a year? Or is it for surgical data 5 years?
Oh,
I think that's a great question.
I think I'll answer that. If we're talking about a CLI patient like this, it's not a relevant question, I don't think. If we can get this to heal and get the rest pain to go away, then that's our primary target. I'm not sure how controversial that is, but I feel like if we're being honest, That really does have to be the principal driver of decisions, is what does this patient need? All of these cases are custom jobs, if you will. So I'm not too worried about whether this is going to be a 3, 6, 12, 18, 24-month patency situation. I just want to see if I can get resolution.
Also,
But interested to hear what the panel thinks.
I guess my question is this graft is really ultimately your antegrade flow. You still have profunda collaterals, I presume, that will supply this SFA, which looks lovely distally to the pop. But this graft, when it goes down, it will go down. So I think it is relevant. I think it becomes absolutely relevant for the duration of this lady's leg. She's only 60, and you have a tied-off native. So I guess my question is, from a surgical standpoint, and I defer to my surgeons, please instruct me. When you start working on this, what's the durability of this, and how does it affect the durability of the graft?
Yeah, so can I start, and then maybe I'll turn it over to Dr. Malik. But I think for this sort of case, I'd probably do the same thing. I'd probably first try to intervene from an endovascular approach. I think kind of what Dr. Hanau was saying, which I completely agree with, is you have to know what you're treating. So in this case, you're treating a wound, so you just want to have this bypass stay open, ideally just until the wound heals at the bare minimum. So if it's not staying open for years and years, that's kind of a debate whether it needs to be open that long. So I think for this lesion, which isn't occluded and it's a vein bypass, I try an endo salvage first with probably some sort of drug-coated technology. In terms of the surgical options, I think it would be a little bit challenging because you're looking at a reoperative field, and you'd either have to replace that vein with potentially an interposition segment if there's still any saphenous vein left, or do like some sort of vein patch, but it wouldn't, or jump to a more distal location in the leg, but it wouldn't be an easy surgical fix. And I think trying an endovascular first approach would be at least my way of doing it. Dr. Malik, what do you think?
Yeah, I agree. I mean, I think these grafts we watch for the duration of the graft essentially. So that's a difficult question to answer. What is? I mean, yeah, you may get an angiographic success now, but you're right. I mean, these bypasses all eventually fail, and you just have to kind of watch them. I agree with endovascular. One thing I was going to mention is, it may be hard to cross because you're going against, it depends on whether it's a reversed vein or not. So it may not be easy to cross from IMA. It may not be easy to cross from below, depending on what orientation they use the graft and what they did with the valves. I thought the entire graft looked diseased, so it's probably sclerotic vein or from the endoscopic harvest. Usually, I think they do pretty well with endovascular intervention, especially the veins, and you just have to kind of watch it. I mean, eventually once this fails, and if this patient's symptomatic, she's got a great profunda. It looks really nice. So, hopefully it doesn't have rest pain and the wound's healed by then I think you may be okay. But if it fails, then I think you're looking at, some sort of other intervention, probably another open intervention if the endovascular has been jailed out.
I think that's a great point, and hopefully, with time, even if it does fail down the road, there's more collateralization and eventually prevent another wound, especially with how robust that profunda is and all those collaterals that are already forming. But I think you brought up a great point. One of the things that you have to know is just how the vein was prepared and oriented, because they're all valves, and so if they weren't lice, you could potentially have a hard time going in a retrograde fashion. You might get stuck in the valves, just like when we do some venous work and we're going from the opposite direction. So I think that's definitely an important consideration. Dr. Hanau, do you happen to have that information on the operative report?
So it's listed as a transposed, non-reversed saphenous. So there was a valvulotome involved. Okay. But yeah, I mean, you're spot on. It looks like it's a chip shot to get in there, and of course, as the cameras are on, I'm not able to get into this dang thing, but we're going to get there.
I think Alfio had a comment.
Yes, thank you. Dr. Garcia's comment is a critical one. You want the availability to maintain patency as long as possible. All that said, with the wound healing is great, but a lot of it comes down to what you think is going to happen if that bypass closes. Because if you lose that popliteal, you're going to be in a critical spot, and bridges are definitely burned. So you definitely want to do something that's going to keep this open as long as possible. At 60, she'll heal the wound, but if it closes and she loses the popliteal, she'll have a problem again, probably not too distant future. I do have a question in terms of, if you're going to treat this, size discrepancy between the vein and the popliteal artery, if you end up with a dissection at the anastomotic line, what's your bailout options?
Open that up to the panel.
Yeah, I was actually walking down that rosy path because I think ultimately, you know, from a coronary standpoint, these are almost always scar and they dilate nicely. But when they don't, now you have to make a decision. The coronaries, it's easy because it's about a 0.5 millimeter difference and maybe bigger for a more proximal kind of ectatic vein. But here it's distinctly different. So my hope would be that you could tack up whatever you need with DCB and
Temper
just
20.
further balloons.
Steve, it may be easier to go on a medial oblique and shoot from the top so you can see that anastomosis open up.
Yeah, I'm getting an obliquity now and seeing if that changes my vision here.
Projection.
There it is.
There it is.
Yeah, what it is.
In terms of treatments, how many of the people in the panel would consider an atherectomy, or would you do drug-coated balloons, stenting? What's your algorithm for this once you cross it?
I don't think atherectomy would be a good choice here. I think just angioplasty, whether you use drug-coated balloon, I guess that's, I mean, there's no data to support it, but probably not unreasonable. But I avoid stenting any of this stuff.
You would probably start with a cutting balloon or something along those lines. This is very fibrotic lesion. And despite the lack of evidence, we would probably still use a drug-coated technology here, probably balloon.
I think this is
Can I
one
ask a
time
question?
where,
Yeah.
What's the
specialty
mechanism
balloon
of
may be
failure
useful.
typically when you have an
you're
anastomotic
trying to
stricture
crack
like
that
this?
stuff.
I assume it's ischemic and then fibrotic and
Yeah, no, great
scar
question.
basically. And then based on that, does DCB make sense, or are you better off doing some type of scaffold based on what Steve presented as well?
Yeah, no, I think that's a great point. So I think part of that depends on the timing. If it's an early stenosis that you see there, it could be technical. But if it's something that happens years down the road, like in this case, it's most likely some sort of intimal hyperplasia. And so I think my preference has been in these cases to definitely use drug-coated technology. I agree, atherectomy is kind of risky in this situation. You don't want to disrupt the anastomosis or the vein, which, can shred it with your atherectomy device. But in my case, I would probably try a drug-coated balloon and see if that opens up the vein enough. And as long as I get a good result, I would avoid a scaffold in the popliteal artery. That would be my approach.
Would you ever laser these? There's no data, obviously, but what's the risk of lasering? Perf, obviously.
I mean, I may be a little more conservative than others, but I probably wouldn't laser it. I'd probably just stick with a drug-coated balloon. I think it's the safest approach, and you're going to minimize your complication risk with that. How does the panel feel about that?
Yeah, it's reasonable. Not to laser.
What about IVUS? Would everyone use IVUS in this case for sizing? Or do you think it's not necessary in cases like this?
I think IBIS would be very helpful post-initial intervention to guide you.
Let me take
as
a
to what
one
the
for
next
Mongo.
step is going to be.
You have radial. Why don't you get a wire in from above and then just pass a wire down? It'll give you where you need to go. If you can, if you have a long enough wire that reaches.
Yeah, no, I'm looking at all the options here. Definitely, if time wasn't a factor, I'd
It's a
probably
cameras
get
are on
that
type of
done.
thing. The
Yeah, you're just kind of
CTO
having to get it done.
the CTO hook of like 45 degrees with maybe a little bit of a hockey on the back end of that would probably give you enough of a torque.
Maybe also a different projection can help you because it's not very clear, in my opinion, what is the anastomosis, the origin.
Operatively, do you guys try to put it on 12 o'clock, 1 o'clock, 2? How do you guys do your distal anastomosis? Is there a standard you try to follow?
Yeah, good question. So I think for the common femoral, typically we'll sew it just anteriorly. And so if you're trying to get into occluded bypass, knowing that you may not see it because it's like a blind segment. For the popliteal, you're typically approaching from a medial end, so you might sew it onto more of the medial aspect of the vessel. So sometimes, everything's a little bit different, but usually from an AP view, you can sometimes see your distal anastomosis.
Yes.
But it really just depends on how you approach it and how deep the vessel is and everything and so forth.
You know, it's cases
So-
like these when you're on live, camera that you're like, it's right there.
Yeah.
Why can't I get in
Yeah.
there?
Yeah. This is only happening because
It's
it's
right
live.
there. It's right there.
So Dr. Hino, can you just walk us through like what you're thinking here in terms of wires, what you're trying differently to cannulate the bypass?
So I've gone to 014 just to get a little bit more touch, a little more feel. Took another shot, as you saw, with the goal of, as you'd mentioned, my intention is to use IVUS to kind of evaluate and treat.
Would anyone, at what point would people start considering coming from above, just even with maybe a micropuncture and a wire just to snare it? Is that an option people would consider in this case if you can't cannulate it from below? And what are your bailouts here?
Yeah, you got a lot of options.
I'll open that up to the panel.
Our options.
Yeah, I mean, there's so many ways that you could probably. I mean, I probably wouldn't stick the graft. Is that if that's what you're implying? Stick the graft and use a wire through there. Doable, but I mean, again, risky. A little bit risky to do. Even with a micropuncture, still, if it starts bleeding, then you're just kind of stuck.
Yeah, I mean, in this case, it's a little more challenging because there's that ilioprofundo bypass, but I was thinking about sticking over the common femoral head with just a inner dilator of a micropuncture and then putting a wire down just to be able to snare it from below.
Yeah.
Still going down.
What size catheter is
It's
it?
a
It's a
bummer.
little big.
It is. It's an IMA catheter.
Okay.
It looks like the touchdown.
it's
maybe
more
I'm
for the-
wrong, is
for
it a
the,
little lower?
Lower, maybe.
Yes.
Yeah,
lower.
right there.
I think
somewhere.
you're south. I think you're north of where the anastomosis is.
Would anyone
right
consider
there.
using EVIS in this location, or is it not really an option?
That would be kind of cool, actually. To see the distal anastomosis. and
Sorry,
see where
Dr. Hanau, I think
the
I
wire is.
suggesting here, but I think it's another possibility. I mean, I
Oh,
think
that might-
that last case we're talking about, trying to get into the SFA versus profunda during an antegrade stick, it'd be a little deeper, a little bit harder to see it potentially in this location, but I think it's another
Yeah,
option.
just do it. Okay, that's fine. Do it.
All right.
Yeah, I'm gonna need some more depth on this.
And so this is the below knee popliteal, right? That's where we're looking? Dr. Hanau?
Yes, sir. More depth. Yeah. Let's see. Yeah.
Yeah, maybe.
Not sure if I'm gonna do this.
Yeah, maybe
Not with
hard
this
just with all
probe.
that scar tissue and the depth.
All right.
And it's
Actually,
a
you
small sclerotic vein, but it's
tried.
worth a shot.
Also, I get
Let me get
the
the
bypass
018
with a
back.
micropuncture needle. It probably is not the. I mean, we stick pops all the time, so probably not the worst. Just to get in there, then get past that anastomosis and balloon your. You're probably gonna end up ballooning. It looks like majority of this graft, anyways. It should probably just tamponade with a micropuncture stick there.
Yeah.
Small 014 wire.
Yeah, I think that would be my approach.
Grab it somewhere superficial where you can kind of see it nicely, and probably should be fine.
Yeah.
Mongo, 018 Mongo.
Sometimes I'll do it in the opposite fashion. If I just need to snare it from below, I'll put in just an inner dilator of a
Right.
micropuncture and then a V18 and then have my main axis from above, so it's kind of almost reversing it in this scenario.
I think we've all had cases where we see the angiogram and it's a pretty straight shot, but even some of these chip shots can become challenging just because it's a little corkscrew or the lumen is anterior, posterior, left, right, whatever it is, to the true lumen of where you're coming from, in this case below.
And having the right oblique, if it's not an AP view, if you have to do a steep oblique, it can be really hard.
Oh yeah.
Have you tried an RAO projection?
I'm going to go actually from above here, just so I can get in and get this done. So there's the proximal.
Remind us where your access is from above.
Radial.
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 Long way.
How far down? So I guess that's another question. You know, from a radial approach, where do people kind of have the cutoff for how far down they would intervene? You know, obviously some of it depends on the patient's anatomy and height, but you know, would you consider doing this radial? Would anyone think that's a feasible option in this case in a shorter patient, or you think it's pushing it too much?
I mean, it depends on body habitus. I mean, you can get from the radial down to the knee, which is where this is, unless they're, you know, 6 foot or something like that. I think you probably can get there. The R2P devices, and even, I guess Boston now makes a long DCB, so you probably can get down there with a lot of technology.
You can also use a 90 centimeter braided introducer, like a for French shuttle in the radial.
I think I think that's a good point. In this case, I think we mentioned that the contralateral side, there was some hostility with the iliacs. Is anyone using steerable sheets to kind of help get up and over in those cases, or any adjuncts to maybe get your sheath up and over and stick from a contralateral approach?
Yeah, even in a case of an aorta bifam, you could use these steerable sheaths and get a secure access from the top.
All right. Well, it looks like got some success from above here.
You see?
Yeah.
Pretty tight there.
Yeah.
That explains a lot.
So at this point, when you have the kind of wires close to meeting, how do people kind of capture the wire? Do they use snares? Do they try to put it in a particular catheter? What's kind of your choice here to get a through and through wire?
I'll just pass it. If it goes, great. Do a couple passes. If it goes, you're excited.
Yeah.
There it goes.
I mean, otherwise, you have to, if you have to open up a snare, I guess it is what it is.
Yeah.
But
What kind of catheter are you kind of pushing your wire into?
probably an 18 or something usually, just a little bit bigger than the wire that you're using, or I mean, you can even have an 035, just depending on where you are.
Yeah.
The bigger the hole, the
Let me have
easier,
you
you know.
get a,
I don't think I've snared something
let's
for a long
do,
time. Mostly,
like a
you know,
long
Dirk and the
four.
group have always taught us, you know, just put it at a side that the
Four
wire likes to
Sterling.
follow, and it'll find the lumen. So
quickly.
And the catheter is pretty large, so you can also enter the lumen.
yeah, exactly.
So I'm crossed here. I think I'm going to try to treat it from above here with a 4 millimeter balloon, just for the sake of time.
Can you talk about some of the options you have available in terms of catheter lengths from treating from the radial when you're going this far down? Do you have, you know, atherectomy, balloon, angioplasty, stenting? Kind of what are your options coming from a radial approach when you're treating the popliteal? Open that up to the panel in terms of what they would think, or Dr. Hanau. Are you thinking about using a POBA, or what kind of balloon?
Yeah, as I'd mentioned in kind of the preamble data discussion, there's not much evidence to support DCB for this. So I'm just going to use a POBA. I was interested to see if anybody took the bait for a drug-coated stent.
What does the panel think? Drug-coated stent, POBA, or drug-coated balloon to start?
I would, yeah, I would.
Depends on the lesion, which kind of lesion it is. I mean, if it's just a fibrotic in the anastomosis, it's
I got nothing.
a different story.
You know, from the DES world of balloon
Go
expanders,
and walk this out.
it never fit in Achilles, Yukon, or Destiny, right? And it's crushable by a big degree there. From a self-expanding stent standpoint, whether it's Zilver or Alluvia, I think that you could do that. Again, it comes back to size mismatch. And it would never have fit in any trial. So I mean, you're well off the reservation on data-driven approaches. I think the simplest answer is POVA, and then if you really had to, I don't have a problem with DCB here. I mean, why not, right? If you had something that would get there, I mean, you can throw the kitchen sink at it. It gives you durability. Remember that the paclitaxel is water driven. So if this is scar, it's got a lot of water, the drug will embed itself. It's not going to be, averse to sitting in there. If it gives you a little bit longer term patency, then God bless you, run with that.
And then what about specialty balloons? So I think someone mentioned it before, but cutting balloon, serenator, would anyone consider using that? Especially if you think this is intimal hyperplasia, is that an option?
It is a fibrotic lesion. I mean, oh, there we go. Now he crossed from
Nice.
below. It is a fibrotic lesion, and generally speaking, angioplasty alone is
Take the
associated with a lot of
one from
recoil.
here.
So our approach in these fibrotic lesions is either cutting balloon or a serenator, followed by a drug-eluting balloon.
Yeah, I think that's a great point. All right, I think we're gonna continue with the lectures. So, Dr. Hanau, can you hear us? And if so, can you give us an update on where you are in the case?
Yes, sir. So we just finished using a 4x220 balloon over an 018 wire from the pedal access. Again, it was a 6 French access. After we had that difficulty crossing, and basically I was able to daughter from above with my wire so we could get that retrograde access. We're going to take a shot here so you can all see what I'm seeing in real time here. And I IVUS this whole thing, and that, that proximal area doesn't look as pretty as this angiogram, which is not unusual for IVUS. Let's see what it looks like down here.
Are you thinking about any adjunctive treatments for the proximal portion?
Not sure yet.
Certainly looks a lot better. Based on your IVUS, was 4 millimeters about the size of the vein graft?
It was a little oversized. It was about 3.5. So I'm occluding my outflow with the sheath and the posterior tib. My target was the AT.
It's much more brisk now.
I'm going to open this up for the sake of... Whoops.
Well, I think for the sake of time, we'll come back to you after the next lecture. So, so Dr. Hanau, I think we're going to turn it back to you for just one final time here. Can you give us an update?
So I'm going to play you back our IVUS result. And one of the concerning areas was that, proximal segment of the saphenous vein, where there was just a lot of material, soft material there that really didn't change much regarding the angioplasty. I know we talked about atherectomy and other things like potential adjuncts, and as I kind of tempted you to consider earlier regarding drug-eluting stent technology as something that appears to have some merit. And so I decided to do that with a 7 millimeter Alluvia stent at the proximal end. So I'm post-dialing that right now. Any thoughts on that?
Panel? So I guess my first question is, what was the size of the vessel, and was this a focal, was this a diffuse or a focal area of kind of intimal hyperplasia that you were seeing throughout the vein?
So can you see the IVUS?
Yeah, we can see it.
Yeah, so you can see that there's a material there that's probably about, 100 millimeters or so long as we come up and down that area. Measuring the vessel at about 8 or 9. So I didn't feel like I was being too aggressive with the alluvia, but the debate is, DCB, POBA, drug-eluting stent, bare metal stent, surgery. I think that's the valid closing thought I'll give to the panel and the audience. I still feel like it's a discussion point that we need to probably have more and more of, especially with best CLI.
I think that's a great point. Panel, any final thoughts or comments on what you do? Would you do the same thing, something different?
We would have used the scaffold also. The other, if it's a shorter segment, we prefer Viabahn in these cases, but if it's longer, then we may consider Illuvia.
I think it sounds
Dr.
reasonable, yeah.
All right. Well, Dr. Hanau, I think for the sake of time, we have to move on, but thanks so much for sharing this interesting case.